Good morning, Misha. Let's discuss hypertension today. I want to focus not just on definitions, but on the different phenotypes. Can you tell me what white coat hypertension means?
Sure, Dr. Fernando. Whitecoat hypertension is when a patient's blood pressure is elevated in the clinical setting, but normal at home or during ambulatory BP monitoring.
Exactly. The stress of being in a medical environment can transiently raise blood pressure. Now, should we treat white coat hypertension with antihypertensives?
No, we don't usually initiate medications because there's insufficient evidence that treating it reduces cardiovascular risk.
Correct. Although it still carries intermediate risk, treatment isn't recommended. Now, what about the opposite? Masked hypertension.
That's when the patient's clinic BP appears normal but is elevated outside, at home, or via ambulatory monitoring.
And how do we manage it?
Unlike white-coat hypertension, we do treat masked hypertension using the out-of-office BP values to guide management.
Good. It's more insidious and has a higher cardiovascular risk than even some cases of sustained hypertension. Now, let's move to isolated systolic hypertension. What causes that?
It's mainly seen in older adults due to age-related arterial stiffening. The systolic BP rises while diastolic falls, increasing pulse pressure.
Yes, and that widened pulse pressure increases vascular damage. What's the key caution in treatment?
We treat it like regular hypertension, but avoid dropping the diastolic BP below 60 millimeters of mercury to preserve coronary perfusion.
Excellent. Don't forget, aortic regurgitation can also cause isolated systolic hypertension. How would we detect that?
Through auscultation and echocardiography, you'd hear an early diastolic murmur.
Now, what about orthostatic hypotension? How do we define it?
A drop of more than 20 millimeters of mercury, systolic, or 10 millimeters of mercury diastolic within 3 minutes of standing,
And when should we screen for it?
especially in older patients or those with diabetes, Parkinson's, or symptoms like dizziness or postural instability.
Good. In such cases, the standing BP is used for guiding treatment. Let's talk about variable blood pressure now.
BP variability can be exaggerated in autonomic or endocrine disorders. Diagnosis needs repeated measurements, including ambulatory and home monitoring.
Right. These cases often require referral to specialist clinics. Now, Misha, what's the most common cause of hypertension?
Primary hypertension, no identifiable single cause. It's polygenic and influenced by environmental and lifestyle factors.
Yes, up to 90%. But when should we suspect secondary causes?
When there's a sudden onset, severe or resistant hypertension, or a strong family history of early strokes or hypertension.
Exactly. And speaking of lifestyle, what are common dietary contributors to hypertension?
High salt, low fruit and veg intake, high saturated fats, simple carbs, and even excess licorice.
Don't forget medications. What drugs can raise blood pressure?
NSAIDs, corticosteroids, oral contraceptives, calcineurin inhibitors, VEGF inhibitors, stimulants, alcohol, and even some antidepressants like venlafaxine.
Very thorough. So, as a future doctor, always think beyond the numbers. Hypertension isn't just high BP, it's a spectrum of phenotypes, lifestyle interactions, and systemic implications.
Thank you, Doctor. Fernando, this was very enlightening.